One. Good morning from Miami Beach. This is Dr. John Bennett hosting a series of webcasts by Michael Segru on connectomics. And let me introduce Mohammed to run the show. Mohammed Helmi, he's awaiting finishing his neurosurgery residency. So welcome, Mohammed.
Thank you, John. So greetings from Shanghai, dear audience. On behalf of the course director, Professor Ben Shu, we welcome you on our fourth broadcast of Seeing the Brain Through Connectomics. This course is broadcasted under the auspice of Asian Congress of Neurological Surgeons every Friday, 8 p.m. in Beijing time. This series of webinars is given by Professor Michael Shugro, who is a neurosurgeon at Prince of Wales Hospital in Sydney, the co-founder and chief medical officer at Omniscient Neurotechnology. Dear audience, you are welcome to write your question in Q&A box throughout the webinar or raise your hand and ask your question directly to Professor Mike after the webinar. Professor Mike, we are looking forward to learning more interesting topics from you tonight, so go ahead, please.
So for those of you who've been actually coming to the webinar regularly, this is the fourth lecture out of 5, and we're going to take a different angle. And what we're going to talk today is about interventional neurorehabilitation. This is a term that we came up with to describe what we were doing for our patients, and we think that it's a really important part of the future of our field. And we're going to talk about how do you rewire the brain actively for therapeutic purposes using a combination of connectomics and non-invasive brain stimulation. Now, this could be the foundation for a lot of other things, but today we're going to talk about non-invasive brain stimulation. So while this is different than the last 2 weeks we talked about surgery and how to cut around brain networks. The foundations that we set in the first 3 lectures are really going to make it possible to grasp this concept. And so again, this is an interlinking idea. There's a reason this lecture is fourth. And the final lecture next week, we'll talk about the next level of how to really understand the next level of how the brain works. But today we're going to talk about how do you change the brain. And I'm going to show you what we know, how we think about this, and going forward. So the foundation of what we do is based around transcranial magnetic stimulation, or TMS. There are other ways to stimulate the brain. This is the one we happen to like. What TMS is not new. It's been around for 30 years. And what it does, if you look on the left, inside of that paddle, there are 2 round coils of electrical wire, and they really quickly have a pulse that goes around in a circle. So for those of you who remember your physics, circular electrical field causes a magnetic pulse at a right angle, the right-hand rule, so to speak. So actually I showed the wrong hand. And that will deliver a magnetic pulse into the head. Now, what we also know is that it will induce an electrical field in the brain if you deliver it the right way. And if you look on the right, that's a model of the field. You can see the coil is kind of shaded here. Now you can see that the brain gets a large part of the brain gets some current. But what I'm going to kind of point out though is that this is not symmetric. And so for the most part, the active site is at that red area. And so when you stimulate the brain, it activates it. If you put that over the motor cortex, it will cause the hand to jump. But more importantly, it shows that we need to be in basically the correct area. So while a magnetic field is delivered, most of these coils nowadays deliver a fairly focal. So it's not a perfectly focal pinpoint treatment. It's not like a DBS, but it's fairly precise. TMS is cleared in pretty much every developed country in the world. It's widely used. There are hundreds of randomized controlled trials. It's extremely safe. We'll talk about these in more detail, and it changes the brain. It's neuroplastic. And this slide is actually probably needs to be updated. This was, I think the last time I updated the slide was 2018, and so these numbers are out of date. But it kind of gives you an idea of how many trials have been done. And again, right now it's cleared in the United States for the depression, anxiety, OCD, and smoking cessation. Though, as you can see, this also goes into stroke and everything else. Now, there are a lot of different ways to deliver the pulses, okay? So if I deliver a single pulse to the brain, what that will do is it will, if you put it over the language area, you'll get a speech arrest. So if you put over the hand, you'll get the hand to jump. But the therapeutic parameters, so again, those parameters have been what people have generally used to do brain mapping, like individual or small trains of pulses. But when we talk about therapy, we mean RTMS, or repetitive TMS. And you can see these are the different pulse parameters. Now, this looks complicated. It's not. So we'll take at the top. 1 hertz means 1 pulse a second. This was kind of the older protocol. 10 hertz, it was kind of the next protocol, so it's 10 times a second. And these protocols require, roughly 30 minutes or so of treatment. What people have moved now is to theta burst. And theta burst, if you look at this, what you do, every single one of these little lines, you deliver 3 pulses. So you're delivering, basically 150 pulses a second or something, like 50 pulses a second. You're delivering a lot of pulses. And you're delivering in this very specific rhythm. And what's been shown is that you actually get the treatment effect much faster. So somewhere between 3 to 5 minutes. And that's a real game changer. Now, the reason it's a game changer is that if you're doing the older protocols for TMS, and if those of you, and what you'll find out if almost all of you, most places have somebody doing TMS somewhere around you. So it's been in psychiatry since the 90s. But what they'll often try to do is work in this upper one. And this is not really appropriate for rehab, particularly post-craniotomy rehab, because the patient can't wait a month every single day. It's too difficult if they have a neurologic deficit. The nice thing about theta burst is you can actually do it 10 times a day if you want. And there's not a lot of downside to that. So what you can do is you can actually get the whole treatment course done in a couple of days instead of a month. And that's a big deal. Now, if you look, there's a couple ways to deliver theta burst. So you can deliver intermittent theta burst, or ITBS. And what that is you give a train and then you stop, and then you give another train and you stop. This is thought to basically be stimulatory. It's thought to turn the cortex up. And on the alternate situation, you have continuous theta burst. This is you just run a bunch of pulses into it. And this is thought to turn it down. Having said that, the literature shows that it isn't exactly like that, but we don't have a better model to predict what's going to happen. So this is kind of a starting point to think about what the difference between these two different paradigms are. There are also different ways to do coils. This is the original coil, it's just a single wire. This penetrates deeper, but neither one of them go very deep. So for the most part, you're actually stimulating the cortex. And the reason is because CSF and tissue are very good ways for current to diffuse out. So it really is only going to get down to the cortex. And so most people use butterfly or some similar type of coil. And the reason is because these two fields overlap in the center. So this little line right here is where the active highest density of current is being delivered. Having said that, there's all sorts of other types. There's all sorts of different devices. This is a device, what's called an H coil. It claims that it can stimulate the caudate and cingulate. There's some data for that. But the point of it is, I can promise you this is not the solution to your problem. It's very difficult to work with. And the question is, how does it work? Now, the short answer is it delivers electricity to the brain, and the brain's in an active state for about 45 minutes. And it seems to make whatever you do in that period likely to induce neuroplasticity. The way that I describe it to patients is it sets the brain to super learn. Now, when you get to mechanistically, how does it work? This is really complicated, because if you think about it, the cortex is folded, it's all these different angles, and then the neurons are at different angles, and they all get different current, and then you have to simulate the CSF field in different scalp thicknesses. And so no one knows the exact answer, but the best theory is that you're essentially turning down the GABA tone in a layer of cortex. And so it makes that area a lot more excitable and a lot more likely to induce neuroplasticity. That's the best way to think about it. But I think from a pragmatic standpoint, what you think about is that you stimulate the part of the brain, you put it into an active state, and then you do rehab. You have 45 minutes where it's in that active state. And if you do rehab in that time, you really get a dramatic improvement in how effective rehab is. That's the one thing that we've seen. The risk of this is the safest neurological treatment that I know of. Okay. The seizure rate it's actually even less than this. It's about 8 in 120,000. So it's very low. Occasionally, if you're over the temporalis muscle, you'll get twitching. So you should put a bite block in. It's a little unpleasant. But most of the time, you can change your currents or do something to get the patient through it, or you can move to another target. So the real thing that, for the most part, these risks are pretty low. Most people, the only real side effect is they might be fatigued or they might not like their jaw twitching. But the key thing is that there's never been a trial that I'm aware of where the placebo group was superior or even that close, to be truthful. So we don't really see people get worse. If we do, it's very, very subtle and temporary. So the way to think about it is you should just try it. And this is my opinion, because compared to the risk of not, getting a good neurological outcome, this is much less than that. Now, another thing about it is this. So as a neurosurgeon, we look at this different than the psychiatrists do. So the psychiatrists traditionally, what they've done and how do you figure out how high to turn the current? Well, what you do is you find the motor response. So you go around the head, you find the motor cortex, and what you see is the thumb twitch. Okay, and then you figure out how high does that current need to be. And then what you've done is you've set the current specific for that patient on that day. A lot of things affect that number, how thick the scalp is, how much sleep did they get last night, caffeine, what time of the month it is for women on their cycle, et cetera. But once you've set that, then the dose is given as a multiple of motor threshold. So you say 80% of motor threshold. That's pretty typical for theta burst. There's some that do 120%. There's different ways to do it, but you set the current to a multiple of motor threshold. So what they do after they get the motor threshold is they get a tape measure out. They go some period space, usually 5 centimeters in front of it, and that's the treatment for depression. There's a couple of things that we know different, right? So we know that measuring things on the scalp is incredibly inaccurate. We know that. And that little pieces of the brain do different things. So if you look here, these two regions in actual space. So this is on the left, in the upper left, this is a paper where experts did pick the target using something other than image guidance. And you can see that the intended target was that red, but of course people hit all over the place. And this difference is, not enormous, but still you can actually look at what the people in the left were hitting versus the people in the right. And if you move a slight bit of cortex, it actually changes a lot, right? So this thing on the left is the structural and functional connectivity of area 46, Robin area 46. And you can see that it's part of the salience network. I'll just trust me, that's what it looks like. And then I move back to 8C, and you can see this is frontal polar. This is the posterior frontal, supramarginal, and temporal. That's the central executive network and has a different structural. So if you move a relatively small part of cortex, you are in a different network. So precision matters. And even though this thing is delivering a field, as I pointed out from the field, it needs to basically be in the right spot. So you don't need to be millimetric, but you really need to be in the right place. And furthermore, if you've just done a brain surgery and there's air and shift and a hole in the brain, the kind of people we treat, image guidance is mandatory, right? And so we've always used image guidance. And so then the question is, what are we trying to do? Okay. Anybody can aim a coil at the brain and start to, just hope for the best, right? And believe it or not, that works sometimes. When we first started doing it, that was kind of what we were doing. But we started thinking a lot, because again, we've treated now hundreds of people. We started thinking, what are we really trying to accomplish? And so the way to think about it is one of three things. One is that you have an area of the brain that's kind of half awake and you wake it back up. Second is you have an area that's out of sync and you put it back into sync. And the third is what you're looking at on this diagram, that you're missing part of the brain and you're trying to get other networks to pick up the slack and do what you're there to do. Now, we know that not every part of the brain can do this, right? So if you cut the corticospinal tract, you can't fix that with TMS, right? It's gone. because it's the only thing connecting to the spinal cord. If you destroy the default mode network, you have nothing to stimulate. But a lot of times that isn't what happens. If you're following the things that we talked about in the previous lectures, saving networks gives you, if you really think through this and try to save what you can, and you think ahead of time when you can't save it, then what you know is you want to keep architecture that you can stimulate. So if someone has a default mode network problem, which that problem, if it isn't immediately obvious what that is abulia, right? That's what these people look like. Stimulating the DMN in our experience, so far I've only done it 3 times, but 100% of the time the patients have made dramatic recoveries. And it's because you have to save some of the network. So thinking about therapeutic rehab before the operation is critical to getting a good result. Here's what this basically looks like, right? So you can see this is a patient with a fairly significant disability. You can see this is a fellow from actually a long time ago. This is an old video. You can see there's a coil. There's the machine. This is image guidance. You can see that what we've done is we've exported a target, the part of the brain we want to treat. And what we're doing is this is an image guided coil, and we're just making sure that that coil is centered on the right part of the correct part of the brain. So if you hear that click, every time it's firing, that's many, many pulses. They're happening so fast that one click is actually, several pulses. And you can see that's an intermittent theta burst. That's what it sounds like. Now, so that's what it looks like. So interventional neurorehabilitation is a concept. It's a concept where we think about the structural connections, which we've talked about a lot. And we're going to talk a lot more about the functional connections, about networks, how are networks supposed to look. And when you think about the wires and what types of signals are going through those wires, what comes out of that is function. So in order to have normal function, you need some wire firing a reasonable way that does that function, right? So when we think about people who don't have the function, who have a deficit, we need to look at the structural connections and the functional connections. We're going to talk about that. Now, what do I mean by this? It's really important to think through this carefully, right? So when you start out, you have a set of wires, right? And there are signals bouncing around the wires. And when that happens, through a very complex set of interactions, certain things fire together, right? They fire, that's what networks are, parts of the brain that fire in sync. Now, when I put a hole in that structure, it's going to throw the signals off because the equilibrium is out of whack. And so first thing that happens is that when I cut the wires, some things stop happening, right? No matter what you cut, that is true. If you cut part of the brain, something stops happening. Now, sometimes the brain can compensate for that, and sometimes it doesn't. Now, if what you cut is the corticospinal tract or the left arcuate fasciculus or whatever, then that may be enough to cause the function to stop happening. We know that if you cut the optic radiations, no information comes from that part of the eye. So that's fairly simple. But when we start talking about cognitive systems, they're not quite that simple. They're a little bit more complicated. But what happens is that in many patients, the damage isn't the cause of the problem. It's actually the brain getting out of sync. The balance is off, and things begin firing with things in ways that they're not supposed to happen. So remember, going back to the concept of networks, which we talked about many times, parts of the brain have things that they're supposed to fire with. And when they don't, this is the cause of disease. And this is actually the cause of pretty much all mental illnesses. This is how they cause symptoms. So let's go to a little bit more description of this, right? So what do I mean by quantifying functional connectivity? So this is a new video you guys haven't seen. And so what you can see is that parts of the brain, as you go through your daily life, fire together. And some things fire together very often, and some things don't ever fire together. So for example, the central executive network regions and the DMN regions shouldn't be firing together very often. They're opposite networks. So I can look and say, how frequently did those guys fire together? and I can put a number on it. That's just a correlation. It goes from 1 to -1. And while there's some things, differences between people and different days, there's a lot of areas that are very consistent. The motor system's supposed to talk to itself. And we know that in some people, it doesn't talk enough or talks too little. We can flag that. So we study that for every possible combination, we get a functional connectome. Okay, so you can see here, all these little names are different regions from the HCP atlas. And there we go. We've actually looked at a functional connectome. So when I say that people have functional disconnectivity, this is what it looks like. So this is what we're looking at here. So on the left is a normal person, and we're looking at the language network. Okay, so what you can see, all of these regions here are parts of the language system. If you're paying attention, there's left 44, that's Broca's area. Left 55B, that's the motor cortex of the larynx. Left SCEF, that's SMA, right? You don't have to know all these, but just know that these are parts of the language network. These are the same things on the y-axis. So every box is comparing each guy to everybody else. If you look at the diagonal, it's blacked out. And the reason is because we don't care that every area obviously is correlated with itself. Now, if you look on this scale over here, 0 means no correlation. What that means is that area A and area B don't really have anything to do with each other. They don't talk to each other. If you look on the blue, that's actually anti-correlated. It means that if one thing is firing, the other one's not. It means they're alternating or one inhibits the other. We don't know exactly why. And the red means that they're firing together. So some areas, for example, if you look in this upper left, these are two parts of the SMA, and they have a dark red square because they fire together very often. Now, over here on the right, this is a patient with a glioblastoma in the archaeofasciculus and aphasia, densely aphasia. What you can see is that you don't see a bunch of red. Now, you do see some red. Look over here on the right. All these things here are the temporal lobe areas, okay? So, and then you look over here in the lower left, these are all the frontal areas of the language system. And notice that when I look at the frontal, the temporal areas with the temporal areas, there's a lot of very dark reds. That's not normal either. It's not good to be over-correlated. It's not good to be under-correlated. You want to be normally correlated. You want to be talking normally. So what you're looking at here is aphasia. This is what happens when you cut a tract and you know the acute period and you damage the language system. Now, why have I spent the time to explain this to you? Well, the reason for it is that these columns are not just numbers. That is right there. It's a place in the brain. So everything in that column is how that one region talks to everybody else. So you get a biopsy on how it talks to the whole language system. And if I know that that area is not firing, I can actually pull it out and put it on my image guidance system. So this is how we think through it. We look at the connectome, we decide what we think about what we're trying to treat. We pick a target based on that. We think what's wrong with the patient and we treat it. Now we built some tools into our software that does this. So you can see what you're looking at here is what's called an anomaly detector. So as you know, again, we don't know how red and blue off the top of our head every single square is. There's 144,000 squares in the connectome, the way we map it. And so we don't expect anyone to know that. But what we do expect is that if we provide the information, that you can look at the red and blue squares and figure out there's something wrong. And what you're looking at here is the default mode in central executive. How do they talk to each other? Right? So if you look at the blue dots, those are all parts of the DMN. The orange dots are all parts of the CN. And every box here is colored one of four colors. The black ones are areas of the brain that are very variable. Now, think about this like this. So if you and I all get in a scanner, so let's say myself and John and some of the Chinese people all get in a scanner. The chance that we're all thinking of exactly the same thing at every moment in that scan is low, pretty much zero. Even if you personally get in the scanner twice, there's some things you're just going to do differently, right? We don't expect that you're going to get identical results. What's interesting, though, is that about 70% of the regions are consistent. And so they're the same pretty much no matter what. So no matter what you're thinking, the default mode network is firing together, right? And so what you see is that the areas that are very inconsistent are blacked out on this because we don't want to treat areas of the brain that just are noisy. The white areas are areas that are consistent, that the patient is normal, and then the red and blues are the outliers. So red is too much and blue is too little. What we're looking at is for a column, because we can only treat one part of the brain. And so you can see if we see a column with lots and lots of squares, we know statistically that it's very likely that that's not normal. Okay, so going through the interventional neurorehab paradigm. Again, structural damage throws off the balance, and we see functional disconnectivity, red and blue areas, parcels that are talking too much and too little to parts of the network. Now, how do we know that targeting this is a good idea, particularly after a craniotomy? So this is a paper that we published this year in Scientific Reports of our first run. We've actually recently published a second paper. We have a growing experience with this, but this was our first round. And so it just took a while for us to write this up and get it through all the gauntlet. But what you can see is that on the upper right, these are aphasia scores and people who had aphasia, and all of them improved. There's one at the very top who had pretty dense problems and got 1 point better, but everyone else, this is pretty serious. And on the right, these are all people with upper and lower motor weaknesses. They all improved. And if you look in these are not trivial. So again, the best one we had on there was a 3 out of 5. That means anti-gravity, but no resistance. And there's a 1 out of 5 there. All of these people were 4+ or better by the end of the treatment, and most of them were normal. Remember, this is a week-long treatment. So while we don't know for sure, based on this data, would these patients have got better on their own, this is really fast. So even if the patients would have recovered on their own, you're getting these patients into rehab, you're reducing the risk of DVTs, you're getting them into radiochemo quicker. It's better to have more function in gliomas. Having an SMA syndrome for 6 months when you have a glioblastoma is not a good way to have a good outcome for these patients. But if you doubted that, then Sandro Krieg in Munich did a randomized controlled trial on this. This was published last year. You can see that what you're looking at is the Fugel-Meyer score, and these are people with injury to part of the CST, like meaning they had diffusion injury, and they randomized them to sham, that's in red, and TMS, that's in blue. Now, a better score in Fugel-Meyer, if you don't know, are unfamiliar with it, is better outcome. And you can see that these curves not only are better in the TMS group, they diverge. It's actually almost 3 times as good, and the number needed to treat was 2. So this is an extremely effective treatment, and I'll show you a case that we have. We don't need to keep studying this forever. It's pretty obvious that it works and that we should be doing this. And again, if you asked me 3 years ago, I wouldn't have said this strongly, but there's not a lot of reason not to do this. And there's now class 1 evidence that at least for motor weakness, that this improves outcome. So how do we think through it? We look at the structural and functional connectome, and we try to correct this. So let me go through 2 cases, and I'm going to show you how we think through it with our software. So this is the first one. So this is an 18-year-old who was 2 years out from a large dominant hemisphere MCA stroke. So first thing we're going to do is we're going to look at the structural connectome. And what you'll notice, this is the language system. And if you were paying attention, this stroke is not, this is not a joke. This is a very big stroke. It's also chronic. So this is 18 months out. We don't think that she's going to improve function, and her language function was pretty poor. The big question is, with the arcuate fasciculus missing, what do we have left to work with? Does stimulating Broca's area, is that going to fix this when the Broca's area is barely there? So what we did, and I'll show you, is we try to say, well, how is she talking in the first place? She should be completely aphasic. So what we did is we looked at the other motor system. We said she's missing almost her entire SMA on the left side. That's in the stroke. And if you look, there's a little fiber there that makes it to the other side. So we started off with the hypothesis that the circuit that she still had left was the right side was her path to function. Next thing we wanted to do was we wanted to look at her functional connectome. Now here, this is a form of the software that basically shows the connectivity on the brain. So it's still a matrix, but there's a matrix there you can view as well. And what we're looking at is, this is a seed in Broca's area, and we want to know who doesn't talk to it. And if you look, the SMA is not really communicating with Broca's area. So that otherwise they would be reddish, but it's white. So we put that seed in Broca's area, and you just don't see anything, right? Because neither side is talking very much. So there we go. That's our target. That's what we decided to do. We looked at the structural connectome, the functional connectome. Now, could you come up with other strategies? Yeah, you could try the temporal lobe. That's still connected. You see, there's the matrix. We can look at how it looks. And the bottom line is, there's lots of different strategies. We picked that strategy. So again, seed in yellow, that's in Broca's area. You see that this should be red. This is a network. It shouldn't be white, and it definitely shouldn't be blue on the left side. This is a right-handed person at baseline. And so you look, the SMA is not talking to it. But the difference is, unlike some of those other areas, there's still a direct connection. It's the only direct connection left. Okay, so that's our target. Okay, that's what we treated. And you can look, we're looking at it from the back. So how did this patient do? Well, within 4 months, when she came back, first thing is that it looked like the fiber bundle was thicker. Now, that could be artifact, imaging. We don't know whether that's true or not. But the nice thing about it is this lined up really nicely with an outcome. The outcome was this patient attends college now, and that was definitely not what she was doing before she met us. So there was no downside to doing this. This is a chronic, serious case, and we wouldn't have thought that someone 18 months out from a stroke would show any improvement. So what this really opens up the possibility that we have been substantially under-treating patients and doing some of them to bad outcomes when we could have done something more. Okay, so here's another case. So this is a post-surgical case. So I'm going to take you through the pre-op first, because this is a little bit complex. And so you can look, this is the motor system, and there's the glioma. So it's a cingulate gyrus tumor, and you can see that it's flying very close to the tree line. It's very close to the corticospinal tract. It's fairly sizable. Now, the interesting thing is, if you stare at this, at first you might think that that's in the motor cortex or underneath it, but it turns out that it's actually pushed forward. And the nice thing about the connectome is you can actually sit down and go through it with the software and figure out specifically, is this the sensory cortex or is it the motor cortex, and how are things pushed? So no more mysteries. Now, again, to walk everyone through it, CST is close, but it's not in it. It's in the middle cingulate. And you can trust me that the other networks, like the Salient network, are in front of it. So now, this was not my patient, but essentially the surgery was done. There was a small recurrence. He wanted to have aggressive surgery, and so he did. Now, this is the patient right the day after surgery. So you can see non-weight bearing, 100% assist. He's basically got a pelagic leg. Now, if you zoom ahead, this is post-op day 6. So this is a physical therapist. She's telling him, just imagine pushing through your leg. This is after 1 TMS treatment. So we treated him once, and that's what he's able to do after one round. And this is on day 3. So as you can see already right now, he's sped up to his recovery. Remember, he was 100% pelagic when he walked in the door on Monday morning. And this is day 5. So now he's got dorsiflexion. Now, maybe he would have recovered on his own, but that hasn't been my experience for people who are densely pelagic, even if they ultimately recover. And the reality is there's not a lot of downside to trying this. Now, to show you the level of function that we got back, again, this is 5 days. So 5 days later, he's like that. He's basically practicing surfing. So if you don't think that that's a shift of the oncofunctional balance and a faster recovery, then you're more skeptical than I am. So how do we do that? So this is post-surgical. So the first question we have is, did we cut the corticospinal tract? Now, we meaning I didn't do the surgery, but I treated the patient afterwards. And the question is, did we cut the CST? Because if we cut the CST, then TMS is unlikely to fix that. So we want to know, what does the structural connections look like? The answer is not bad. Motor cortex not removed. We didn't do anything terrible. Okay, but he's densely plegic. So remember, if you remember that diagram, structure plus function equals, or functional connectivity plus structural connectivity equals function. So if he's missing the function, one of the two of them is likely out. Okay. So what we now want to do is we want to say, how does the motor system talk into itself? Because we can look at its structural. Okay. So you can see this is that system. Now, a couple points. So that yellow is a seed in the other motor cortex. Now, in that trial that I showed you, they treated the opposite side. And we do that too. Okay. So if you put a seed in that yellow side, you can see that there's a very dark red area. This is the standard thing you see in these patients. There's overactivity on the uninjured side, and that's bad. Not good to be overactive. So you want to turn that down. So that's one of our targets. And then we also, in addition to how Sandra Krieg did it, we like to treat on the ipsilateral side too. So if you look, we put a seed in that motor cortex, the SMA is blue. So we don't know why it's blue. Maybe something in the cingulate we removed threw off the time. It's infinitely complex. Maybe we bumped into that network and it's out of sync. We don't care how it happens. We can't predict that. But that was another target. So we turned down the dark red spot on the left side, and we turned up the SMA. Now, if you remember, paid attention to protocols, that's CTBS, that's a suppressive protocol on the good side, the left side, and ITBS, intermittent theta burst, to the SMA.
Good morning, John.
Yeah. Yes, Mohammed?
So, walking everyone through it, that dark red thing, that's two connected, and that dark blue thing is not connected enough. Those are our two targets. So what I hope I got everyone across, we could spend hours going through all the types of cases. We could talk about how do you treat mental illness. There's a whole different set of, and we'll dive in a little bit into how emotions and cognition probably happen in the human brain. That's our next time. But I think what I hope I've convinced everyone is that we need to take things like TMS seriously, and that the tools have made real quantum leaps over the last few years to allow us to look at a very complicated case that we would not have known what to do, and to make a plan that actually works. But it also opens up the possibility of all the ICU patients and all these patients that we haven't been treating, that we've kind of just hoped for the best. We can actually take control and get some of these people out of a mess. And
I
so,
don't have a question. I'm not.
So
Okay, thank
anyway,
you, Professor Mike. Actually, it was very interesting and so complicated for me too. So I have a question about, you say in the language mapping, there was some places where they fire together. So was that due to pathological disturbance or chemical disturbance, usually?
So the way to think about it is the networks always fire together, right?
Yes.
It's what think about it in the sense, think about this, right? So let me give you an analogy. Think about the stock market. Okay. It doesn't seem like it would have anything to do with the brain, but actually has a lot to do with the brain. They're very similar. So think about, you have this investor over here who thinks these things, and then he talks to this guy, but he doesn't talk to this guy. And this guy hears that these guys are going to do this, and he changes his bid, and all this stuff happens. Okay. Now, if all of a sudden one of these big players decides that they're going to sell all their Amazon stock, there's going to be a chain reaction. And what comes out of that is the price of stocks. So it's hard to predict all of it. It's really complex because there's lots and lots of players, and they all interact with each other. But what we know is that if you all of a sudden cut out a bunch of them, they're going to hit a new equilibrium. and certain things are not going to inhibit each other anymore, or going to inhibit each other. So, for example, there's some parts of the brain that shut other parts of the brain off. We know that. Well, if I remove that the part of the brain is going to become overactive. So, for example, if you think about the motor cortex, if I injure the right side, the left side becomes overactive because now you don't have the balance. And that turns out, the theory is that's not good, because the good side prevents the bad side from healing.
Mhm.
So you shut it off so that the other side can pick up and start functioning correctly. So the thing is that the way to think about it is that the brain is always active. Even if you're not using the motor system, it's firing with other parts of the motor area. Think about it like a car keeping itself warm. The engine's running.
Mhm.
And if you damage part of that system, the timing's off and it's going to start. And what a resting state fMRI does is you just lay in the scanner and I listen to the machine. That's all you're doing. But in that case, what we looked at is we said, this system's out of sync. It's not talking correctly, even though it's still there. And we've all had these patients, right? So if you've actually thought about it, everyone who's done a lot of complex brain surgeries had someone wake up weak that you didn't know why. And then there's no stroke, you didn't get in. So we just kind of chalk it up to swelling or whatever. But sometimes these patients, if you follow them out, they don't really get all the way better. They still have a deficit. And what we found a lot of times is when the corticospinal tract is fine, it's actually these areas are out of sync, and that you can actually fix that really fast. So that guy who we treated, his CST was fine. We didn't give him a new corticospinal tract. We just made sure the motor system was talking correctly. And so he didn't need to be paralyzed. We just reset him.
Okay, great. So the case with stroke, it was 18 months after stroke?
Yes.
Oh my God, that's so interesting. So it get drastically improvement within 4 months, right?
Yeah, I mean, the answer is she had some advantages. She's young, et cetera, but she didn't get better on her own. She had 18 months. And when we first met her, she could talk in 2 to 3 word phrases. And now she's attending university, right? So there's no debate that helped, because we don't expect any improvement at that point. What it opens up is the idea that a lot of things that we were taught about prognosis are only true if you don't treat patients with these type of modalities, right? And so if you think about all the trauma and all the subarachnoid hemorrhage and things, yeah, some of those people are probably injured beyond hope, but we haven't really looked. We don't really know that. And inevitably, there probably are a few people that if you treated them would make some improvement. The nice thing about rehab too, though, is one of the challenges with brain stimulation for depression, for example, is that it works. There's no question on that. It's that it works for a while, and then maybe 6 months later, a year later, the patient has to get retreated because you're fixing a rhythm issue, and then they drift back into the bad rhythm. But when you get someone's arm moving, they continue to use it, and they actually they rehab themselves after that. So a lot of times what you're trying to do is speed up the use of that limb, and so that they can rehab faster.
Okay, great. So can we conclude that the patients with structural damage, but not that much functional disconnection, can get more benefit from the TMS?
So the patients, in my experience, who do the best are the structure is basically fine and the function is out. Because remember, you probably just reset them to the better rhythm, and then those patients can improve really quickly. Now, the second best patient is the tract is there, but it's kind of thinner, and you're trying to get more out of that corticospinal tract, and they don't get as dramatic of a result, but they do improve. If the corticospinal tract's gone, there's nothing you can do about that, right? I mean, now it doesn't mean you can't help that patient, but you can't fix that problem, right? You can't fix the optic radius. You know, if you cut the optic nerve, you're not going to make someone see. These are obvious facts, but you have to say. And that's why when you get into the discussion of the previous lectures that we did, you absolutely should try to preserve networks, because otherwise you can't rehab cognitive problems if they happen. So I'll give an example. And also, if you don't know you're about to go through the default mode network, then you're just going to sit here and be like, I don't know what's happening. So a while back, Charlie Teo came to me with a case, and it was a pretty young guy who had recurrent glioma. It was a low-grade tumor, but it had transformed to high-grade. It's obviously GBM at this point. It's enhancing, and it was invading the default mode network on the left side. So we talked to him, and he, young, had kids, wanted to be very aggressive. And we told him, your default mode network is full of cancer. So more or less, you're going to eventually lose this. We could try to save it, but we're probably not going to save it in the long term. Or we can take it out and do TMS. And so he took the second one. Now, we told him what was going to happen, that it was exactly as we told him, 100%. So he took it out on a Thursday or something. And then on Monday morning, he rolls in. He was basically not talking. He was not really looking at it. He was kind of like this. He was drooling on himself, and he looked terrible. By the end of the week, his wife said that she thought he was a little bit emotionally distant, like he wasn't as emotional as he was, but to us, he looked fine. And what we did was we stimulated the parietal part of the DMN because we knew that we had injured the DMN. We expected to do that. We saved the salience network, and we knew what we were going to do. And so, again, if you haven't thought through that ahead of time, then you might have taken up part of the salience network too, because you thought, I'm going to get 1% more tumor, and that's a bad idea. So what it gets down to is you want to really think about what architecture am I impacting and what can I do about it. And so when you start thinking about the connectome, and you have this tool in your back pocket that you can actually go back and fix these problems sometimes, then you think the operation is different, right? You say, okay, exactly. What are we really dealing with?
Exactly. Actually, it's so interesting. And it's also interesting to have patients like with upper motor deficits. The motor strength was almost, I saw one of the graphs was 1 out of 5, and it got 5 out of 5 after 1 week. That's so interesting. So is there any patients for that?
Well, the reality of it is that, again, you have to differentiate who has structural disconnection from the spinal cord, who has problems inside of the motor network, and who has functional problems inside the motor network. Because if we think that everyone with hemiplegia that you're operating around the motor cortex are the same, I promise you that is not true, 100%. And to give an example, we did a research project with a group in Hainan about a year ago, and they were looking at lacunar strokes, pericapsular around the internal capsule, and corona radiata. So they're really in an area about this big. They all had hemiplegia, and that's it. They didn't have any other deficits, so no language. These aren't hemispheric strokes. These are all lacunes, and the lacunes range in size from really small to slightly small, but none of them were big or even medium size. We looked at the structural and functional connectome of 32 people, and there was not a single person there weren't any group of 2 people who were even close to similar. They're all different every single case. And what it'd be is like, well, okay, some people have overactivity of the bad side, some don't. Some of them have the SMA is the problem. Some of them are missing the corticospinal tract. Other ones are missing part of the sensory system, and that's it's much more complicated than that. But clinically, all these people look exactly the same. Lacunar, hemiplegia. We would all treat them the same. We put them on, What the reality is, those patients have very different prognoses. And to be honest, some of them respond great to TMS. Because if it's not the motor system that's destroyed, it's the sensory system. Well, that could throw the balance off and cause a hemiplegia. But you can fix that, right? They still have connections. They might have a deficit, but they're not plegic after that or paritic. So one of the things about it is what we have to just recognize is that the motor system is a lot more complex than the motor cortex connects to the spinal cord. That's how we thought about it, but that isn't how it works, and everyone knows that. And so what we need to think about is how do we intelligently go through the facts and do something about it, right? And as we've shown, and again, we've got other videos too. This isn't, we have entire talks about this. Of patients who, have had operations that by all accounts, like around the internal capsule, should be paralyzed, but the capsule's fine. and it's a functional connectivity issue. And those patients can be fixed very fast in many cases if you hit the right areas.
Well, that sounds so interesting. Actually, we have to seize the opportunity that you are here in China and to have you in Khashan Hospital.
Yeah, I think I'm scheduled to go. I don't know when though, but yeah.
Yeah, great. Okay, I will not take more of your time, and we'll take maybe if we have any question from the audience or the panelist attendee. So you are very welcome to ask. I think Professor Ben is here.
Is Ben listening? Can he comment? Ben, are you there? He could be tied up.
Actually, he's out of his home because there is a quarantine in the area that where he lives.
Oh,
So,
okay. Okay. Very good. I don't believe we have any pending questions, Mohammed.
Great.
Yeah. So that was really, really interesting webinar. Actually, we are looking forward to more interesting topics next time. That will be the last webinar of the series. So again, on behalf of the Professor Benshu, the course director of this webinar, we have to deeply appreciate and thank you, Professor Michael Shugro, for all of the things that you have showed us. And also we need to thank our audience for being loyal throughout the webinars, and see you next week.
Thank you, everyone. Thank you, Michael.
Yeah.
And we'll see you next week.
See you guys. Bye-bye.
Okay, we stop recording.